Okay. So, hi guys, we are in Lodi at the Memorial Lodi Hospital with the pioneer of KA TKA, or better, calipered KA TKA. And we spent a beautiful, incredible week here. Thank you very much. And so we have the big opportunity to make some questions to our mentor, Dr. Stephen Howell. And so, who is Stephen Howell? A visionary?
A visionary? I don't know. I always wanted to be the best that I could be at something. And I always wanted to be an Olympic swimmer, but I was never that good. But now that I found surgery, I'm trying to be the best that I can when I do knee surgery. And I started in ACL surgery back in 1986, 87. And the parallels from our ACL experience and total knee are very similar. So our ACL experience, we learned about complications, roof impingement. When the tibial tunnel was too anterior, we couldn't extend the knee. Then we learned about a vertical graft causing PCL impingement. The patient couldn't flex the knee. So with ACL, we learned that if you're better at putting the graft in anatomically correct, that the knee recovery was better and the patients had higher satisfaction, less loss of motion, and better return to sport and function. So in 2005, we decided to switch from ACL to total knee because 20 to 25% of my patients were not happy with their total knee, and it made no sense to me. The implants look like a knee. We can fix it quickly with cement so we can move the knee, so stiffness shouldn't be an issue. So why didn't it work like a normal knee? The only explanation that we could find was it was not positioned correctly. And then we developed the kinematic alignment concept initially through PSI with the Otis knee. So the first patient-specific guide used in a patient, as far as we know, was in January of 2006. And then we added the femoral tibial guide in February of 2006 as well.
What's calipered, KA, TKA? Simple words.
Simple words. So, calipered kinematic alignment restores the native joint lines. Why caliper? Because you don't know if you've restored the native joint lines until you've measured the pieces of bone that you removed and make sure that the thickness of the parts of bone that you take off match that of the thickness of the implant after you correct for the thickness or kerf, as we call it, KERF, kerf of the saw blade, and the wear from the cartilage. So if we take off the same amount of cartilage and bone that we put back with metal on the femur, metal on the tibia, and plastic for the insert, then the knee should have a normal articular surface, hence the hip knee ankle angles restored to normal, the Q angles restored to normal, and the joint lines restored to normal. And then the knee should move comfortably with a quick and easy recovery, less stiffness, less motion loss, and less unhappy patients.
And what is a paradigm, and why, in your opinion, the paradigm may shifting from mechanical alignment to kinematic alignment?
So a paradigm is sort of the collective wisdom of a scientific community, where the scientific community, their total belief is that this is the way to do something. So in the old days with physics, there was classic physics, that was the paradigm, and then who came along but Einstein? And Einstein gave a different type of physics called the theoretical physics, and to make the change from the old to the new required a generation. And Max Planck said that it really takes a generation to sort of die and a new one to come in to take over and make this change. So what's the paradigm in alignment and total knee arthroplasty? Currently, it's mechanical alignment. What's the future paradigm? It will be kinematic alignment. The patients will want that. The surgeons will want that because it makes their life easier, it makes their surgeries quicker, it makes the recoveries quicker, it reduces the number of patients they have to see back for follow-up visits, so it lets them finish earlier in the workday. So it's a benefit all the way around. Patients are happier, surgeons are happier, and so KA now with 8 randomized trials published, none from designer or surgeons involved with an implant company, all independent of that. From around the world, 5 show KA has a better outcome in some measure, whether it's alignment, function, motion, patient satisfaction, kinematics, and only 3 show KA is the same as MA. There is not a single randomized trial showing MA is better than KA. So with this large number of randomized trials coming from different parts of the world, collectively showing that KA is better or at least as good, then I think it is going to have a strong impact on how the paradigm moves from currently MA to KA. And I predict that within 5 years, the paradigm will be kinematic alignment.
Talking about kinematic alignment, many colleagues are worried about varus tibial component failure, patellar femoral instability, and long-term implant survival. How can you reassure them?
That's a good question. All 3 are good questions. And we have had all the problems of tibial loosening, tibial wear, patellofemoral instability, but we have not had a big problem with long-term survival. And let me explain. In mechanical alignment, everybody's worried about a varus component on the tibial side because they see varus tibial loosening. In kinematic alignment, we don't see varus tibial loosening because we really don't put the tibia in varus. We restore the native joint line. So if the patient's native joint line was 3 or 4 degrees of varus to the mechanical axis, that's what we're going to restore. Mechanical alignment people take most of the varus joint lines and do a valgus malalignment. That then widens the gate, it widens the moment arm, and therefore the adduction or the load on the medial side of the joint goes up with mechanical alignment. It's reduced with kinematic alignment. When we had problems with tibial component failure with kinematic alignment, it was due to a sagittal plane error, placing the slope of the tibial component in generally greater slope by 5 degrees than native, or in one case, a reverse slope. So the reverse slope jammed the flexion space, the patient kept loading the back or posterior edge of the tibial component and it subsided. In the others where the slope was excessive, then the flexion gap is loose and the tibia slides anterior on the femur and you load the back end of the plastic, the back end of the tibial component, and it fails with a posterior mechanism. So if you don't want to have varus tibial loosening, do kinematic alignment because we don't see it. If you want to reduce your risk of tibial component failure with kinematic alignment, match the slope if you're using a CR insert. If you're sacrificing the posterior cruciate, a reasonable argument can be made to place the slope a little bit less than native. So that takes care of tibial component failure. It is really not a problem for us anymore with KA as long as you use the verification check that when you cut the tibia and you look from the medial side that the cut matches what would be the proximal surface of the articular surface of the tibia. And if the slope's the same, then you have markedly reduced the risk of tibial loosening. In terms of patellofemoral instability, we wrote up a series of 13 failures, probably have 15 now, haven't had one in 4 years. Because the cause of that, like the tibia, was excessive flexion of the femoral component. It's not a kinematic alignment problem, it's actually probably a problem for mechanical alignment as well. When you flex 5 degrees, the implant reduces the size. If it reduces the size, you have less trochlea to capture the patella. If you flex 5 degrees, then the reach of the flange, proximal, is moved distal 5. So it takes longer for the patella to get in the same spot of the groove. We had problems when the flexion was greater than 7 or 8 degrees from native. So what's the solution to that? Don't flex the femoral component. So we have a verification check where we see the side of the top of the notch, the anterior femur, and we put our positioning rod halfway between there, and that reduces the risk you're going to flex the component, and that's worked very reliably for 4 years. Some people say, oh, you have a femoral component designed for mechanical alignment. How can you use it with kinematic alignment? Well, Charles Riviere at Imperial College, as well as us, we published papers where we took off the shelf standard femoral components, Triathlon, Vanguard, Next Gen, Persona, Medacta. We positioned them on models, mechanical alignment and kinematic alignment, and asked a very simple question. Which alignment method best restored the native surface of the trochlea? Kinematic alignment, kinematic alignment, kinematic alignment. And you say, well, why would that be? Because kinematic alignment restores the native hip knee ankle angle. It also restores the native Q angle. And what happens with mechanical alignment? Talk to Johann Bellemans. 70% of people have constitutional varus alignment. When you restore them to a quote, a neutral mechanical angle, you've increased your Q angle at least 3 degrees, sometimes 5, 6, 8, 9 degrees. And now you have an increased Q angle, which compromises your tracking. So kinematic alignment is the best of all worlds. Not only does it restore the native joint line, but it also restores the native Q angle, as well as the native hip knee angle. Long-term survivorship, 10-year study we published, our survivorship was 2 times better than the mechanical alignment survivorship for the Vanguard knee published by Lombardi and Barron. So, and again, why? Because we have a better balanced knee, we have, we know the causes of our failures, slope and excessive flexion from a component, and we can reduce the risk by using verification checks in the operating room.
And finally, which is your message to young surgeons of all the world?
Well, I think that the young surgeons are in an ideal position. I look back to my day, and I think about the ACL, and I remember I only saw 3 of them in my training. And I remember when the attending, who was very nice to me, he checks the knee, he goes, "What do you think of that?" And then I don't want to say anything, but I said, you know, that doesn't look as tight as maybe it should be. So I learned 2 things. One, that there's an important operation that needs to be done for athletes, and 2, I think there's an opportunity to do it better. So I think the young surgeons have probably had the same experience with some of their senior surgeons. They say, look at that knee. And you sit and look and say, well, it doesn't quite straighten, or it only bends to 105 degrees, or it might bend perfectly, but the patient doesn't like their knee. And when you see that patient, if you're like me, you're going to question and say, why? If the knee that we put in has the same shape, more or less, of the native knee, why doesn't it work normally? And I'll submit to you that the problem is the alignment method that was used in that case, and what's the solution? Kinematic alignment. So the young person has an open mind, and keep it open, investigate, give this a try, and you don't have to do the severe deformities first, do the easy ones. And the best case to try it on is someone that has a mechanically aligned knee on one side and maybe isn't as happy with it as they'd like to be. What do? You do kinematic over here. You don't even have to tell them. Just say, I put the knee in. And I bet they'll say the recovery's quicker, the knee feels more normal, the motion came back quicker, and they're happier. And what will they do to you? They will send you their friends. And you'll get very busy, and you'll be very happy about it.
Thank you very much.
Very
Thank you very
much,
much, Stephen. We are really kinematic alignment and so open-mindedly and for sure inclusive and not exclusive. Do you
Exactly.
agree?
I would agree with that completely.
Okay. Thank you very much.
Thank you.
Thank you very much for
Thank you
visiting.
very much. Thank you.
17 knee replacements in 4 days.
Yeah, 1 week, 17.
Yeah, very good.